from the American Academy of Pediatrics.
Sometimes pediatric exams can seem intrusive to our patients.
An updated policy statement reiterates the use of chaperones during these sensitive exams.
We're in this to provide comfort to our patients, to make sure that they are comfortable when we perform examinations that can, of necessity, involve uncomfortable situations.
Plus, we'll discuss a new advocacy curriculum for pediatric emergency medicine fellows.
So much of what impacts child health happens outside of the clinic and hospital and emergency department walls. And advocacy is really one way that we can have an impact on that aspect of child health.
These stories and more on Pediatrics on Call, a podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a discussion about the use of chaperones for pediatric and adolescent encounters.
Joanna, I'm curious, in your work as a board-certified lactation consultant, do you ever feel like you need a chaperone in the room?
Does the baby count? I don't, because the birth parent is an adult, and I always ask their consent if I'm going to assess their chest or help them with the latch. And often the focus is on the infant and their skills, but why do you ask?
Well, because sometimes the nurses I work with look annoyed when I ask them to step into a room when I'm rounding on a breastfeeding mother. But beyond that, it can be tricky to know when we need a third party for an encounter and who that person should be.
Especially if it's not a baby, but a teenager. So I definitely agree with you, David, and I know who can help us with those questions. Let's welcome Dr. Jesse Hackell back to the show. He is a retired general pediatrician with more than 4 decades of experience in practice. He has served the AAP in numerous roles and is currently the chair of the Committee on Pediatric Workforce and is one of the authors on an updated policy statement, Use of Chaperones for the Pediatric and Adolescent Encounter. Jess, welcome back to the show.
Thank you. It's a pleasure to be here with you.
Just 3 years ago, we endorsed an older version of the statement, and now we have a new one. What has changed in the practice of pediatrics that compelled the Academy to release the update, or was there something else?
Well, not much has changed in the medicine part of it exactly, but a lot has changed in terms of how we conduct our encounters with our patients. One part is the introduction of telehealth, which provides a new way to deal with patients and to examine them that we hadn't considered before in the earlier statement. The other issue with the older statement is we wanted the new statement to recognize that different practices of different sizes and with different staffing capabilities have different constraints in their ability to provide staffing for chaperones at all visits. What we really wanted to make sure is that every practitioner who's seeing an adolescent understands that consideration of the adolescent's privacy and comfort is important, and that they have a discussion within their practices to determine how they will address the question of chaperones, even with limited staff availability.
And as someone who works in the NICU, I mentioned this before, I'm examining babies. I have over the years matured in my practice and always explained to families why I need to examine inside a baby's diaper. Am I right in thinking we should explain the exam starting on day 1 of life? And at what age do we absolutely need to start talking to our families about what we're going to do?
Well, I always think it's good as a pediatrician with a lot of experience that we participate in anticipatory guidance with our families. And that means from our very first encounter, we should be involving the parents initially, and then as the child grows older, the child as well, in everything that we do with them. So I think it's important that they understand why we're doing what we do, the reasons behind it. And it's especially important as the child gets older. One of the issues in pediatrics is that we are often examining parts of the child's body that may be considered sensitive or private by the child. And this varies depending on the child's age and maturity level. But nonetheless, we know that as they get older, children do develop a greater sense of privacy and sensitivity about their body. And it's important that we respect that and take that into account whenever we're examining a child, because after all, it's important that a child be comfortable when we're interacting with them during an encounter.
And is there an age where we absolutely need to start having a chaperone in the room?
I don't know that there's a specific age number where that takes place. I think it's much more important to consider how the child is reacting to what you're doing and what you're proposing. I think that some children early on may be more sensitive than others, and we all know that there are adolescents who seem to have no sense of privacy or shame at all. So I think it does vary a lot with the child, and that's why it's important that we involve them in these discussions early on, because as we develop a relationship with the child and with the family, we get to know them, they get to know us, and we get a sense for where they are in terms of their maturity and their needs and their sense of privacy and all those issues which will govern our decision about a chaperone.
And ideally, who should our chaperones be? Is it enough to just have a parent in the room?
Well, ideally, we would have a chaperone who is somebody with medical training, a member of the clinical staff, a clinical team taking care of the patient. That's important because one of the things that we're trying to accomplish by having a chaperone is to assure everybody involved that the examination is being done appropriately, it's being done according to the usual standards, and that it is in fact necessary. So somebody with medical training is better able to assess that. Now, that's not always necessary. It's not always requested by the child or the family, but nonetheless, that's sort of a guideline for the optimal choice of a chaperone, although, optimal is subject to a lot of different conditions.
And may we talk about gender? It can be hard sometimes in pediatric practices to find male medical staff members. How important is it that the chaperone's gender match the patient's?
Well, there's not a lot of good study or research on this, but what does exist suggests that it is not a hugely important part of the criteria for choosing a chaperone. When male adolescent patients were asked, most of them did not have a preference at all for the gender of a chaperone. And female patients, when they were asked, often preferred somebody of the same gender, but in fact often preferred a same gender parent to be the chaperone rather than a staff member. So the choice of gender is, unless the child expresses a specific preference, that's less important than the presence of somebody as a third party to be participating and observing the examination.
And what if the patient identifies as transgender or non-binary?
Well, unfortunately, patients who identify as gender divergent have often suffered traumas in previous examinations and may be, in fact, more sensitive to these issues during the course of an examination. But it's important that there's no one answer to that question, but rather the individual patient in the individual encounter that we're dealing with is what really should govern our choices.
And I want to ask about something that has certainly happened to me when I went in on the weekends and clinical staff didn't show up. What do we do if we just don't have anybody around to help out?
Well, that's a problem in a lot of circumstances. As you said, when you go in and on the weekend and you're alone, it's a problem. It's also a problem in smaller practices, which may operate on very small numbers of staff members. We don't always have a clinical team member who's available to participate as a chaperone. And in those circumstances, we need to be flexible. We need to be willing to accept a parent or a non-clinically trained staff member who can be there to give the patient some comfort. And that's the important time when we need to ask the patient what they are most comfortable with. Again, many adolescents are extremely comfortable with a parent being an additional party and would prefer that rather than having somebody who's a relative stranger with them. On the other hand, there are circumstances where the patient would prefer it not be the parent. And again, it's the desires of the adolescent patient, the desire to provide the greatest degree of comfort for them during what could be a difficult examination that really should govern our choices.
And just I suspect my experience is in common with a lot of our colleagues that we don't always have clinical staff to spare. Sometimes we don't have clinical staff at all when we need a chaperone. What do you recommend for practices or providers under those circumstances?
Well, in a smaller office where you may have one or two staff members who are busy doing a lot of other things, you may not have people readily available to come in and be a chaperone when you need them. And so what's really important is for those smaller practices to discuss in advance how they're going to handle this situation, because there will be situations where you absolutely will need to have a chaperone. And even the smallest office can make arrangements to do this by involving whatever clinical staff they have, or even non-clinical staff who've received some special training as to what is expected from a chaperone.
And in those circumstances, is a parent an adequate chaperone then?
Yes, occasionally it has to be the parent because you have nobody else. And, we've all had the experience of coming in on a Sunday where we're the only person there. And it's important in that circumstance that you explain, probably even more carefully, what you're doing, what's required in the examination, and make sure that you make everybody as comfortable as possible with it. There may occasionally be a circumstance where you cannot complete the examination at that time because of the lack of somebody else in the room. And if that's the case, you do need to make arrangements for follow-up care and for completion of your assessment.
And when we sit down to document, because that is so important these days, what do we need to make sure we put in the chart about chaperones?
Well, I think when we're documenting an exam where we have had a chaperone, we should make note of the fact that a chaperone was present. That's the first thing. In addition, it would be ideal to use the name and, if appropriate, the clinical position of that chaperone. Again, this is important because it documents that we have followed our best practices. And there is also the fact that documentation can protect the physician in the unlikely event that there's a misunderstanding that leads to a conflict or a difficult situation with the parents. So having the documentation of the chaperone, if used, is important. And just as important is documenting when the patient refuses to have a chaperone. It's important that we offer it, and it's important that the discussion with the parent and with the patient is documented as well. This is a prime opportunity for the use of shared decision-making between the clinician, the parent, and the patient to come up with a solution that's acceptable and optimal for all.
Well, Jess, I'd love it if you can help me with another question from my own experience. I always offer my adolescent patients a moment of privacy to ask and answer confidential questions. Do I need a chaperone if we're both dressed and just talking?
Probably not. But, again, that's an important thing that you have to assess at the time of the visit. It's usually the examination, whether it be visualization or palpation or touching of a sensitive area, that should have a chaperone present. On occasion, you may get into a sensitive discussion where it would be helpful to have somebody as a third party present. But I think those are pretty uncommon, especially when we've already gone through the discussion of what would make the adolescent patient most comfortable during the situation, during the proposed examination.
And what about telehealth when the patient is somewhere else entirely? Do we need to consider using a chaperone? And if so, how?
That's an interesting question, and it comes up more and more now as telehealth does take a bigger place in our clinical armamentarium as a tool by which we can extend access to care to more people. Telehealth visits generally don't involve as much sensitive examination. It certainly doesn't involve touching of a sensitive or private area. Nevertheless, if there's going to be an encounter that involves a sensitive examination remotely, it's probably ideal to have a third party involved as well. And that can be difficult, obviously, because you're not in the same location as the patient. And that's a circumstance where you have a couple of options. One would be, in that case, to use the parent as a chaperone next to the patient during the telehealth visit. At least the parent could help to assure the adolescent that nothing untoward is being done or visualized on the camera. It's also an opportunity that you can have a chaperone from somebody in your office who is observing, either on the same screen or on a different screen that you can link into the visit for the same reasons, to observe that the discussion and the examination, such as it is done appropriately. And finally, most telehealth platforms have the ability to record an encounter. And while this may not provide any real-time comfort to the patient, it does give the opportunity to review a visit should any conflicts arise at a later time.
And just this policy statement is so important that I hope all of our listeners will go read it. Before they do, can you leave us with one takeaway?
Yes, I think the main takeaway is that we're in this to provide comfort to our patients, to make sure that they are comfortable when we perform examinations that can, of necessity, involve uncomfortable situations. And so taking the time to share the decision-making with the adolescent patient and with the parent, if appropriate, can help ensure that we meet the needs of the adolescent patient for privacy, for sensitivity, and really for attention to their needs. So sharing the decision-making and involving the adolescent in the discussion, again, it goes back to what we started with about doing this from the first visit, is involved with building a relationship and making sure that every encounter is as comfortable as we can make it for our patients.
Dr. Jesse Hackell, thank you so much for joining us today.
Thank you. It's been a real pleasure.
To read the policy statement, use of chaperones for the Pediatric and Adolescent Encounter, go to aap.org/podcast.
Coming up, we'll look at a new advocacy curriculum for pediatric emergency medicine fellows.
David, I know you're on adjunct faculty at UNC. Do you get to teach much?
Well, I do precept, and I have some ad hoc lectures I give when I can gather a few learners together. But the one regular didactic I give is on advocacy. I know that's a passion we both share, Joanna, and I'm fortunate enough to address the students quarterly during their pediatrics rotation in Wilmington.
We talk about it all the time in the NICU because so much of what we see has a social and political component. But I think pediatrics is unique in having advocacy as a competency for accreditation and board certification going back more than 2 decades.
I know we didn't talk about it much when I was on the internal medicine side of my training, and yet social and political forces impact everyone's health, so I'm surprised advocacy isn't part of everyone's medical education.
Well, I know someone who would agree with you, David, Dr. Megan Attridge. She's the lead author on a new pediatrics article, Development and Evaluation of an Advocacy Curriculum for Pediatric Emergency Medicine Fellows.
Dr. Attridge is an attending physician in emergency medicine at the Ann and Robert H. Lurie Children's Hospital of Chicago and assistant professor of pediatrics and emergency medicine at the Northwestern University Feinberg School of Medicine. Megan, welcome.
Thank you for having me.
So, Megan, unlike for pediatric residency, advocacy education is not required for a pediatric emergency medicine fellowship. What makes you think it's time to include it?
Yeah, so As we all know as pediatricians, just like you mentioned, so much of what impacts child health happens outside of the clinic and hospital and emergency department walls. And advocacy is really one way that we can have an impact on that aspect of child health. And like you all were mentioning, so many of us were lucky to have trained in the last 2 decades where we received advocacy training during our residency, but really, just because we continue on to subspecialty fellowships doesn't mean the advocacy stops. So advocacy can really be an important part of our career as subspecialists. And we believe we should continue on during our subspecialty training. Especially as pediatric emergency medicine physicians, we commonly care for children experiencing poverty and with conditions that are chronic that might be exacerbated by other social and political factors like you mentioned. So we as PEM physicians can really use our expertise to provide a voice for children and their families through advocacy.
And was there one particular case that made you think, this has got to stop, I have to do something?
There are so many that come to mind. I think most recently living in Chicago, every case of firearm injury that we see in the pediatric emergency department, I think really impacts myself and my colleagues.
And when you brought up this idea of an advocacy curriculum with your fellows, how did it land with them? How excited were they to advocate?
So I can call myself out here that I was actually a fellow when we started this curriculum. So with my mentor, who's lead author on this study, Jennifer Hoffman, I got to participate in this development of an advocacy curriculum. And so I, for one, as a fellow, was extremely excited. And I was lucky enough to be amongst a group of like-minded fellows who were really excited to continue their advocacy education throughout their fellowship.
And I've never developed a program before. Can you tell us what all that involves? It strikes me as really daunting.
Yeah, so this was a learning opportunity for me as well. We used a framework called the Kern and Thomas 6-step model for curriculum development, which was really useful and is commonly used in medical education curriculum development. And that includes, the first thing is problem identification, which we kind of already talked about. The next step are like general and targeted needs assessment. So that included a literature review where we identified there weren't many, if any, studies describing advocacy curriculum in other pediatric subspecialties. We also met with program leadership or fellowship program leadership, as well as leadership in the division to discuss an advocacy curriculum. And we also administered a questionnaire to both faculty and fellows to identify perceived advocacy-related needs in our division and in our specialty, as well as gaps in our own skills and knowledge. So that was kind of the first step. And then from there, we were able to identify our own goals and objectives about the advocacy curriculum. And using those goals and objectives, we built out our lectures, as well as another component of the curriculum, which was a mentored longitudinal advocacy project.
And what sorts of projects did you and your fellows undertake?
Yeah, so this was the most exciting part to participate in and write about later. And now as a director of the curriculum, it's probably the most exciting part as well. So the fellows did a number of different projects that we described in our case study, our advocacy case study. And one group worked really hard on firearm injury prevention. So they formed partnerships with hospital organizational groups and piloted a distribution of safe storage devices for firearms to families that presented to the emergency department. They later received a grant and were able to expand that work into other areas of the hospital. They also built relationships with state legislators and our hospital government relations team, and were able to join an effort to promote state legislation for a safe firearm storage campaign, which was eventually signed into law, which was very exciting for all of us. They also published an op-ed in the Chicago Tribune calling for a statewide ban on assault weapons and large capacity magazines. There were a couple other really inspiring projects too. Another cohort developed a program to expose underrepresented minority students who were family members of emergency department staff to careers in healthcare and science and technology. And they developed a really fun curriculum that included CPR training, workshops that introduced ultrasound and stethoscope skills and interpreting x-rays and splint making. And then another group kind of explored COVID-19 vaccine hesitancy. This was in the year 2021 when we implemented this advocacy curriculum. So they were able to kind of explore why caregivers might be hesitant to get their children the COVID-19 vaccine.
I am really inspired hearing about these projects. You guys did so much. I feel like compared to skills like, say, intubation or starting a line, advocacy can be a harder competency to assess. How did you gauge learners' success?
Sure, a number of different ways. One of the ways was really just the completion of the longitudinal project that we just talked about. We also surveyed our participants before and after the implementation of the curricula to assess their attitudes, knowledge, skills, as well as their participation in advocacy activities. So given our sample size, we couldn't characterize significant change, but we were able to describe that our fellows endorsed positive attitudes about advocacy before and after the curriculum. After the curriculum, fellows also reported agreement in their knowledge of advocacy-related issues and their ability to conduct specific advocacy activities. And then I also mentioned we had a free response component of the survey where fellows could demonstrate their knowledge by identifying legislative representatives as well as local advocacy initiatives or hospital advocacy initiatives. And after the implementation of the program, they were able to identify their state and federal legislators. They were also able to name several advocacy initiatives. And after the curriculum also, fellows were able to endorse engagement in a number of different advocacy activities, like social media advocacy, using a blog or website for advocacy, and in participating legislative advocacy.
Do you expect this program is going to become an integral part of pediatric emergency fellowship training in more places than just where you are?
I hope so. There are already a few awesome pediatric emergency medicine fellowship programs who already include advocacy training in their programs. I think we were just the first to maybe describe it in literature. There's also an advocacy subcommittee of the AAP section of emergency medicine that is in the process of putting together some resources that are accessible to fellowship programs and hopefully will make the implementation of advocacy training a little bit easier.
Well, if our colleagues are as impressed by this work as I am, I'm sure they're going to want to go and read this paper. But before they do, can you leave us with a takeaway?
Sure. I think that the takeaway for me is that advocacy is important for every pediatrician and every pediatric subspecialist. And I think that we are right to include as much advocacy training as possible in our fellowships and really beyond.
Dr. Megan Attridge, thank you so much for joining us today.
Thank you so much for having me.
To read the article, Development and Evaluation of an Advocacy Curriculum for Pediatric Emergency Medicine Fellows, go to aap.org/podcast. This week, instead of our Say Ah, we're sharing a special Giving Voice. This one involves two pediatrician colleagues.
Dr. Catherine Hoops is a firearm injury prevention researcher and legal scholar who sat down with her critical care colleague, Dr. Elizabeth Mack, at the 2024 AAP Advocacy Conference to discuss gun violence in America and what drives their advocacy work. The audio starts with Dr. Mack.
I don't think people understand when we say that, this is the number one cause of death of children in this country, that we mean it. I mean, I remember testifying at one point about permitless open carry in our state. And on that day, there was not a single law enforcement officer or a single healthcare person in support of the bill. And yet it sailed through. And on that day, I had 6 children in our ICU who had been shot in our ICU. I'm not talking about like their finger got scratched. They required, either they lost their life or they required critical care. And I just remember feeling so defeated because I somehow didn't feel like I was able to convey what I see to this audience. And, it didn't have the impact. It didn't land on them like it did on me. And so do you need to be able to literally see it with your own 2 eyes for it to mean something? I don't know. And that brings me to the same question you asked me, which is what gives you hope after those really defeating moments?
Oh, gosh. I think, I just have to believe in those kind of situations that if we could work toward a system where we could step outside of our echo chambers and look at each other and actually listen, right, that we would find so much more common ground. And I don't know how we get there, but it gives me hope to imagine that we can if we keep trying, and so I think, my faith, my children, my hope for a better, safer, more equitable future for them, my love of the community that I get to serve in my city, those people, those relationships, they, on hard days, make me put one foot in front of the other, right? And try and I really do mean to put one foot in front of the other, to reach out to the other side, right? Because I think there's so much more common ground on these issues. And I know I just finished articulating, if I wave my magic wand, then all the things that I want. But, I heard one of my favorite law professors say that compromise is the oxygen of democracy, right? And, as much as I might want all of those things way on one side, right, that incrementalism is still a pathway to things getting better. That's still a pathway to kids being safer, and I'll take it.
Thank you, Dr. Catherine Hoops and Dr. Elizabeth Mack, for giving us your voice.
The story was recorded in partnership with StoryCorps, a national nonprofit whose mission is to illuminate the humanity and possibility in us all, one story at a time.
Learn more about StoryCorps Studios at www.storycorps.org/studios.
Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll discuss the diagnosis and treatment of atopic dermatitis.
We'll talk to the author of a new clinical report, Dr. Jennifer Shook. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.